Welcome to this Nutrition Nuggets educational webinar series, and this is the third webinar so far. And today you'll hear from the Princess Maxima team in Utrecht. The title is Tube Feeding in Pediatric Cancer Patients, the Multidisciplinary Approach. So welcome. Over to you, Team Princess Maxima.
Good afternoon. Thank you for the introduction, Nerifu. We are ready to take you along about this topic, tube feeding in pediatric cancer patients, the multidisciplinary approach, because we are with several disciplinaries here. I'm Bianca van Rossen, pediatric oncology nurse.
My name is Doris Kouwenberg. I'm a pediatrician and a pediatric oncology fellow here at the Princess Maxima Center.
Hi, my name is Salome. I'm a pediatric oncology nurse on the stem cell unit.
Hi, my name is Janette Dekker. I work as a pediatric dietitian at the Princess Maxima Center.
And my name is Sophie. I'm one of the child life specialists in this hospital.
We would like to give the words to Dr. Kouwenberg.
We start with sharing our screen. So if all is correct, I hope you are all able to see my screen. And as you are aware, we are today presenting from the Princess Maxima Center, which is the pediatric oncology center for all children who are treated for cancer within the Netherlands. Our mission is to cure every child with cancer with optimal quality of life, and nutrition is an important part of that. Let me first introduce you a little bit into the reason that the Princess Maxima Center came into being a couple of years ago. And for that, it is good to know a little bit more about how the Netherlands is organized, actually. As you will be aware, probably the Netherlands is a very small country with 18 million inhabitants on only 42,000 square kilometers. So we have a very high population density. And a relatively good infrastructure with all cities and towns connected to each other. In our country, we have approximately 600 new pediatric cancer diagnoses every year. And these 600 new diagnoses are spread out over many different disease entities, which makes every disease in its own very, very rare. And prior to 2014, there were 7 pediatric oncology centers spread across the Netherlands, which made that all the pediatric oncologists didn't have that much experience with every different disease entity. The 600 new pediatric cancer diagnoses are spread out through the different kinds of wards that we have, and about half of all the diagnoses are hematologic malignancies. Approximately 30% is solid tumors, and approximately 25% is central nervous system tumors. But because of this issue of a lot of different diagnoses, which each in its own are very rare, it was decided that oncology care should be centralized a couple of years ago. And therefore, the Princess Maxima Center was instituted. It has been open since 2018, so we are now in our 7th year already, and approximately 900 care providers and 450 researchers work here, just to make sure that we can provide the best of care. And we are situated in a central place in the Netherlands, which is shown on this map. Princess Maxima Center is located within Utrecht, which is a very central city within the Netherlands. Of course, we cannot provide this care with the Princess Maxima Center on its own, so we work together with a lot of so-called shared care centers, which are hospitals in other parts of the country, which can also provide care, for example, for febrile neutropenia or for transfusions or other types of care in closer by home. Of course, as you are all aware, childhood cancer has some serious effects on the nutritional status of our patients. As you know, it encompasses several severe illnesses. for which an intensive treatment is often required with chemotherapy and or radiotherapy and or surgery. And these intensive treatments can cause several problems. For example, nausea, impaired taste, pain with eating and with swallowing, diarrhea, and renal dysfunction. And as you can imagine, these adverse events of treatment can lead to malnutrition and failure to thrive, possibly. On the other hand, increased appetite can also be caused by some types of medication. And when patients are very ill, they might have decreased physical activity. And that might lead to obesity. And our task as care providers is to balance these adverse effects and to make sure that we do not let our children get malnourished. But on the other hand, we would also like to prevent obesity. And that is an important challenge for us as care providers. In short, we can provide nutritional support in several ways. We would prefer our patients to have a normal diet or an as normal as possible diet. The first step is to provide information to help parents give some protein and energy enrichment to the normal diet that they are already giving their children. If that is not enough, then we can provide nutritional supplements, so like drinking feeding that can help optimize the nutritional status of the patient. Today we're going a bit more into tube feeding, which can be given intermittent, which is a more natural way, but if that is not possible, it can also be given continuously during the day. And if that is not a good option to be fed enterally, we can also provide parenteral nutrition, which is luckily not needed in the majority of cases. And I would like to give the word to my colleague Jeannette to go further into tube feeding in itself from a dietitian's perspective. Thank you.
Yeah, thank you, Doris. Today, I am going to tell you a bit about tube feeding at the Princess Maxima Center, and I'll do this using a case study. And I will explain when tube feeding is indicated, what type of tube feeding we use. I'll tell something about different types of feeding tubes, and I'll discuss the various methods of administering tube feeding. Let me introduce you to Nick. Nick is a 16-year-old boy diagnosed with rhabdomyosarcoma with lung metastasis. And currently he's at the end of his treatment and undergoing chemotherapy maintenance. At the time I saw him, he was admitted to the hospital due to a fever. And because of this, his maintenance chemotherapy had been paused until further notice. And on the right side of the slides, you can see Nick's growth chart showing his weight for age. And as you can see, his weight dropped by more than 1 SD in a very short period, down to 46 kg. And this drop with more than 1 SD in a very short period, that indicates acute malnutrition. Nick's energy and protein intake had been around half of his requirements for the past several weeks. Nick had trouble swallowing and he felt full quickly. He was feeling miserable and his parents were very worried. And previously, we'd spoken to Nick and his parents about high energy and high protein foods. And he had also tried oral nutritional supplements, but this was not very successful. So the next slide is there a tube feeding indication? Well, there's clearly an indication for starting tube feeding in Nick's case. First of all, as we saw the previous slide, he is acutely malnourished. And secondly, as we also saw in the previous slide, his intake is below 50% of his requirements. And actually, tube feeding could have been considered earlier when intake was between 50 and 75% of his needs. But Nick, like all teenage boys, Nick struggled with the idea of getting a feeding tube. He didn't like the thought of being seen with a tube and was anxious about the placement procedure. But still, he recognized that tube feeding could help him feel better, and eventually, after talking to him about it, he agreed to have a feeding tube placed and to starting tube feeding. And this slide is about the different tube options. And most children at the Princess Maxima Center, they receive a nasogastric tube. And this was also the case for Nick. Sometimes a nasoduodenal tube can be used when gastric feeding is not tolerated, for example, in case of a gastroparesis. And sometimes children receive a PEG tube, for instance, when a nasogastric tube cannot be placed due to tumor location. However, this is not common practice at our hospital. At the Princess Maxima Center, we use this flowchart to determine the most appropriate tube feeding formula for our patients. If there are no other problems, we start with a standard tube feed with fiber, which is optimal for maintaining good gut health. Our preference is to start with high energy formula, which has 1.5 calories per ml, unless there's a contraindication, such as inadequate fluid intake. The advantage of high energy tube feeding is that it delivers more energy and nutrients in a smaller volume, which is helpful for patients who can't tolerate large volumes. And we generally choose a formula appropriate for the child's age, unless the child's weight is significantly below what's expected for their age. In that case, their weight guides our choice. And children over 12 years of age are given adult formulas if their weight is above 45 kgs. But perhaps it's good to mention that many children at the Princess Maxima Center, they suffer from mucositis due to chemotherapy. And these children are given semi-elemental formulas, which are easier to digest and absorb, as the nutrients, such as the protein, are partially broken down, and the formula contains no fiber. Nick had no symptoms other than early satiety, and therefore we chose a standard high-energy formula with fiber for him, and that was an adult formula since his weight was above 45 kg. There are several ways to administer tube feeding: continuous, intermittent, or bolus feeding. With continuous feeding, the required amount of formula is administered slowly over 24 hours using a feeding pump. This method is used when a child experiences gastrointestinal symptoms, such like fullness or nausea, as it improves tolerance. Sometimes we choose for intermittent feeding, and then the tube feeding is given during a part of the day, for example, overnight only, in addition to the patient's own intake. And the third option is bolus feeding. And bolus feeding can be used when gastric emptying is normal and the gastrointestinal system is functioning well. And the advantage of bolus feeding is that it mimics normal meal patterns and allows more freedom of movement. For Nick, we chose continuous feeding because of his early satiety. His feeding started at 20 ml per hour and was increased in steps of 5 ml per hour up to a target rate of 70 ml per hour. At this rate, Nick received 100% of his nutritional requirements. He was also allowed to eat and drink as he desired, in addition to the tube feeding. Nick tolerated the feeding well, and after just a few days, he felt significantly better and looks visibly improved. For both Nick and his parents, it was a huge relief that the pressure to eat was gone. Nick was discharged from the hospital with tube feeding, and we discussed bolus feeding with the parents and how to adjust the feeding schedule when Nick started eating more. After 2 weeks, Nick's weight had increased by 1.5 kg to 48 kg, and he was able to resume his maintenance therapy. After 3 weeks, his oral intake had improved significantly, and it was decided to remove the feeding tube. I hope this case has demonstrated how tube feeding, whether short or long term, can be a valuable support during pediatric cancer treatments.
So this is from a Dutch point of view, and this is how we do it in our hospital. But when children will get a tube for the tube feeding, we as child life specialists guide them. So we prepare the children, and we do that because we think it is important to be honest and predictable. Our main goal is to help the children develop while being in hospital. And if there are lots of threats, we see that children stop developing as well as they should be. So this is why we tell them. And so what do we tell? We tell facts and not too much about what the child will experience, because we know that because we don't really know what they will feel and experience. And if we tell them by using frightening terms, it might scare them. If we say it will be painful and itchy, we know for sure that it will be painful and itchy. So we try to use facts, show them where your nose are, where is your belly, where do sandwiches go, or where do your food go, so that they see on a picture, and where the line will go into the nose, around the corner, and right, and that the nurse will stop when it is in their stomach. So these are the facts that we tell. The other thing is that we try to use language that will encourage them so that they will feel empowered. We always tell also our nurses, and we do it ourselves, if we give children a compliment, we tell them a compliment of what they've done very well and very brave. Exactly in what they did. So not you did very well or you did very good, because sometimes it's a little bit empty. If you tell the children, because of you sat so perfectly still, I could help you so quickly, or you were helping me so well when you were drinking when I put the tube in, this way it went very fast, and the child really knows that they did something well, and we hope that confidence will grow. Also, we'd like to ask children how they felt that it went. So not to tell them how it went, but how did they experience it? And if it was a negative experience, then that's also possible, and we will be there for them. We won't be trying to solve it, because we can't always solve it, but what we can do is to listen to them and to be there for them. And then I put down tube as a threat. We see that many parents and also children itself, of course, don't always want a tube, and parents see other children in hospital wearing a tube, and it frightens them, and they think, oh, I don't want my child to be having a tube. So sometimes what they do is they try to encourage their children to eat, but they use the tube as a threat. So please eat this, because if you don't do that, then you will get a tube. And then if the point is there that they need a tube because they can't take their medicine, or they have to eat so much and they can't because of the chemotherapy, then the child feels as if it's a failure. I didn't do well, or I should have eaten more. Well, they really couldn't, because the food didn't taste well and it was really hard eating that much. So we always try to explain to parents and also then to children that the tube is not a threat or a punishment, but the tube is there to help them. It's a doctor's trick. How nice, you don't have to take your medicine anymore because the doctor will help you. Now it will go into your tummy immediately and you don't have to do anything for it. Or you can't eat 5 plates, but we can put 5 plates into your stomach if the doctor thinks it's necessary. So we try to explain in that way. And the other thing I put down is the processing via play. If children go to a store, they will play a store at their house, or they will be a cashier. And if children go to hospital, they will play as if hospital or being a nurse or being a doctor. This is processing and understanding the world, and it's really important to understand then what has happened and to play with it. So my advice will always be to have all the materials that a child sees and gets, that it's there for them to play with, and they can maybe give the tube to a doll, and them being the nurse. It's really important to play. If you play, you understand. So I think that's it.
Wauw, mooi. Dankjewel.
All right, I will tell you something about some practical nursing aspects. At first, when we give our patients a feeding tube, it's important to first check the tube before you use it. At first, you do a visual inspection if you see the tube in the throat and it's not curled up in the mouth. And then you're going to check some aspirate on acidity. Sometimes you don't get immediately some aspirate. So what we do, we wait sometimes half an hour and we let our patients move a little bit or sit more upright. And then we get some aspirate to check. We always want to be the acidity below 5.5. Sometimes you see it's above 5.5, and it's important to keep in mind that it can be caused by some medication. When it is, you can try to let your patient drink some lemonade with low acidity and check after that, and then you mostly see that your acidity is below 5.5 and you can use your tube. So it's important to be sure it's good in the stomach before using it. Then Jeanette already told something about when do we give tube feeding continuously or bolus or intermittent. We see a lot of children with continuously tube feeding, especially when they're in an intensive phase of their treatment. It's difficult to eat and have all the nutrition they need, but also they get a lot of medication. So sometimes you also need your tube for the medication. What's important, it's not an indication to stay in the hospital. So we have a lot of children going home with tube feeding for all day or just sometimes only in the night. So we discuss with a dietitian, but also with parents, what do we all think the child needs and what is okay to do in the home situation. But after this, Bianca will tell something about that. Then a practical issue, sometimes your tube is stuck. We give a lot of medication and tube feeding about it, so sometimes you have an obstruction. It's important to try to open it with just normal water. Sometimes we hear the story to try other things than water, but that's not working, because when you try with some soft drinks like Coca-Cola, it has a really low acidity, and sometimes it's getting worse when you try that. So it won't help to solve the blockage. So you just use some warm water to open the tube again. And it can also help to do a little bit kneading on the blockage on the outside to make it a little bit more soft, and then you can rinse it with water, and most of the time that's enough. Then another practical issue, sometimes the kid will vomit, and it's important, what I told in the beginning, it's always important to be sure that your tube is in the stomach. So you really have to check the acidity to be sure that you can still use it and it's in position. When the child is vomiting and sometimes the tube will come out through the mouth, it's important to remove it as soon as possible, but especially to stay calm. It will be a little bit scary maybe for your patient, so important to just stay calm and to take it out as soon as possible.
Thank you, Salome. Well, we now come to the last part of our presentation, and I will tell you something about safe tube feeding at home. At first, I'd like to add to what Salome already told us, that a tube, the feeding tube, is not a long tube with a hole on the end. Because if you do that, the feeding and the medication will come in one point in the stomach, and that is not it's not a nice feeling. So to get more slow administration in the stomach of the medication and feeding, the tube is like a long tube, but with little holes in the end on the side. So it will divert in different directions, and it will be softer to accept in the stomach. We always explain that to parents, and that's my first step. The instruction to parents or caregivers. In our country, it is obligated to instruct to parents or caregivers to give the tube feeding and medication safely at home. We have a plan in little steps because parents are full with information already or emotions. Well, we decide what is the best time for them to tell it. When they are going home, most of the emotions already got a little place. So, and they really would like to get home, and that is what is needed. So we, in the patient's file, we make notation of what the parent or the caregiver has already done. Does he understand it? Has he shown that he can do it? And therefore, in the end of these steps, we can say for sure that it is safe to use the tube feeding at home. We tell them all about the aspects that Salome told, when they are stuck or when the patient has vomited, so they know what to do in unexpected situations. And we have a special company who let the parents rent the feeding pump. And this company also takes care of all the materials that are needed at home to give the tube feeding and the medication to the child. There is a home care organization nearby at the home of every child that is also really very well organized, if I may say so, in the Netherlands. And this home care organization is the backup for in case there are any problems, it is stuck and it won't go away, or it has vomited out, the patient needs a new tube. You don't have to go to the hospital. At home, the home care will take care of that problem and solve it with you together. And this is real important because the life and the schedule of the family is least interrupted because home care can help you. Because we all know that the tube feeding will not be there for 1 month, but most of the time it is a larger period of time that the child needs the tube feeding. My last point about this is if there's a language barrier, then it's even more important to be sure that the information about giving the tube feeding at home is clear to the parents. Sometimes you need an interpreter to translate all the information. Well, if it's really difficult information, you need a professional one. But in this case, you can also use a family member who can translate it very well from English to their own language or from Dutch to their own language. And that's also a safe way to give these instructions. The last thing I wanted to show you is the bridle. It's a fixation of the nasal tube without plasters needed. It's a fixation around the nasal septum with a small plastic wire. And you see in the picture that there is a clip on it that is specially made for this size of feeding tube that this child is using. So it will get the tube, it connects the tube to the clip, and you don't need air blasters. Think, for example, very little children who gets them out all the time. That's really a problem because every time they need a new one, it's really stressful for the child and for the parents. But also, if you think about stem cell patients who have a graft versus host sign, and the skin is really agitated that you cannot put any plasters on it, you don't need it in this way. It has been given under sedation by an ENT, a doctor who will put it there, and it can be used for 3 months, the bridle switch, and you can change the tube through the clip to disconnect it and put a new one in. So you can use the bridle for 3 months, and you can switch, as protocol is in our protocols, every 6 weeks you can change the tube. If you would like to know more about it, I would like to add that my colleague Agnes Visser has a presentation about the bridle on the SIOP Congress in Amsterdam in October, on the 21st of October to be exact. Well, thank you for your attention and for your interest in our presentation. And now we would like to go to the next phase where we can discuss or we can answer your questions.
Thank you very much, Team Princess Maxima, for your presentation. It's interesting. May I just, there are some questions on the chat, but can I just check for my question first? With parental teaching, does your team do the teaching, or the company who hires out the set do the teaching?
Oh yeah, thank you. That's a real good question. The company who delivers the pump and the materials, they tell the story once, only in theory, and our team does it in practice with a real tube feeding that night or that day of the medication on their own child. So we take care of that together. Yeah.
So it's a team approach. And then your shared care hospitals, do they also have the same teaching? Because your patients might go to the shared care hospitals.
Yeah, our shared care hospitals, they can check our protocols, and we also do the teaching of the nurses together. So in that way, the information is the same, yes.
Sorry, I have a question here in the chat. So what is your experience with cultural differences with the use of tube feeding?
Wat hij zo zeggen?
That cultural, some cultures, they are not very and they're not interested in the tube. Is there any problems that you encounter in your center?
Yes, I think we do encounter those problems from time to time. We treat a lot of different patients from a lot of different cultures, and we see that people from other cultures might be hesitant to use tube feeding, either because they are hesitant to stop their own feeding that they like to give from home, and otherwise because they are concerned that it might not benefit the child to have a tube in situ, because they are worried it might give complications. So there's an important task for all our care providers to really explain to the parent and to the patients how tube feeding works, what are the indications, and in what way a child might benefit from it. And I think the case presented by Jeanette, our dietitian, really illustrates that very well, even though there was not a cultural difference in that aspect. Yeah.
Thank you very much, Doris. So there's another question here, but before I ask that question, can I just check, when you pass the nasogastric tube down, sometimes you don't get the test as a positive test to acidity, because when it's acidic, then you know that it's in the right place, right? So in that instance, what do you do to ensure that the tube is in place, apart from giving a drink?
Yeah, that's a good question. Sometimes when you don't get some aspirate, you just wait and try some other positions, and then you get some aspirate. But when you don't get something to check, or you check and it's below 5.5, you have to discuss with your doctor what you do. And sometimes we have to remove the tube and place a new one. And sometimes they will choose to make an X-ray to check if it's in right position.
Yeah, so that's good because in GOSH, we also use X-ray as a determination of the tube position, depending on the patient. Because if it's too difficult to repass the tube, say, for example, the child has quite a few times repassed the tube, or having CVL problems and there's no alternative means to give medicine or feeding, we would, as a last resort, check with an X-ray for the
Yes.
position of the tube. Because in the past, there has been reported incidents where the tube wasn't in the right place. And that's the rule in our trust that we cannot assume that it's in the right place if the following checks are not done. Thank you. So let me ask this question here. Can you tell us about your experience with gastrostomy? Which pathology and when? So when would you use gastrostomy if nasogastric or nasojejunum fails?
Well, as Doris and Jeanette already mentioned, we do not very often have that kind of need. But now there is one child in my dorm who has the process, the oncology process is in the face and in the nose. So the gastronasal tube is not possible because of the dangers of risks there are with the tumor over there. So he got one, but then we used the protocol from the hospital next door. That is the Wilhelmina Children's Hospital. They have a lot of experience. And some of the older nurses here, okay, like myself, we know it from before, and then we teach the other nurses how do you clean it, how do you make sure it doesn't get stuck, and we instruct the parents. Yeah, but it's very, very uncommon that we see that here. Yes,
I think less than once a year.
Yeah, I also think so. Yeah.
So you don't have to go into the gastrostomy as often, but you have surgeons who would insert the gastrostomy, right?
Yes, we do.
Princess Maxima, you have?
Yes, we do.
Yes.
Yeah.
Okay. So may I just check another question from me? It's just for discussion, really. So if the nasogastric tube fails for any reason, maybe the child is really not interested in it, very, very obstructive. So how long would you allow the trial of trying, persuading, etc.? How long would you allow that before you go on to the next step of feeding? Because very often in some trusts, in some hospitals, the tube itself allows for medication administration, and that's where the problem is. So do you ever encounter a reason to persuade the child, and if that fails, then what?
Well, if that fails, then I think as a team, so with your oncologist who is in charge, with your team from the ward, with your dietitian, you decide like what risk do we take if the body weight is getting smaller and smaller and smaller, and what moment do we decide together this is not okay. And the next step is of course a parenteral feeding, but then you also have to give all the medication IV. It's a big infections problem, to give a child a lifeline like that for everyday feeding, and you have to check your labs every time with parenteral feeding. So I haven't seen that step very often. And I would, Jeanette is sitting next to me. She is, I think, talking about all the options to give more calories to the patient at home to prevent that the tube is needed.
Yes, and sometimes it's also dependent on what the next step in what's expected on when will the child be able to pick the eating up by itself, and can we accept that for a short while? And it's always balance. It's always a balanced decision.
Yeah. And do you discuss that weekly? Maybe every week you balance this again with the team, or every 2 weeks?
No, I think perhaps maybe even several times a week.
Several times a week. Yeah.
Yeah, because in the Maxima Center we also have as dietitians, we once a week we attend the doctor's how do you see it?
The ward rounds. Yeah.
The ward rounds, and then we also discuss the nutritional status of the patients, and that would be a very good moment to discuss something like that, like that. Yeah.
Okay, so one more question I thought in my head. So when you send a child home and the parent has been taught the tube feeding, and if one night, the child vomits the tube out, are the parents taught to insert the tube again?
No.
Or they get sent to the hospital?
No. No, they just make sure that the rest of the night is okay. Don't worry about the tube, leave it out. And then the home care organization who is connected to this family, you can call them and you can make an appointment to insert a new tube at home. And if there's really a problem like vomiting with, like I say, there's some blood, vomiting, and you are scared, then you always can go to your shared care center in the neighborhood. But we never teach parents to replace it because it's too invasive for a child to experience that from your parents. But I have to say, if children get older, you can also learn them to do it themselves. So they take out the tube in the morning and they bring it and they insert it again in the evening and have the tube feed during the night. So they can go to school without any distraction of a kind that you are sick.
Oh, that's interesting, isn't it? So you have patients that would do that.
Yeah.
Yeah, they won't mind going and putting the tube down a few times. They are older, I guess. They understand.
Yeah, and they own it. They own the situation.
They're in control.
They're in control. Yes, yeah.
Oh, that's good. Yeah, it's good practice. So now, someone mentioned about the bridle. I wonder if you could put it on the chat, the link of the supplier of that device, because I noticed in the picture it goes through both nostril. So one tube.
It is
yeah,
one.
If you share that slide again, Yeah.
Okay.
If you can share the slide again, there are two. I noticed there are two tubes. One go to the one nostril, and the other one goes. So the children won't mind.
The green one goes all the way around. So it is a small plastic fiber who goes all the way around the nasal septum and then comes out again. So
Okay.
it is
It's the same. Yeah.
Yeah, it is it's a loop. Thank you.
And do you have families complaining or children complaining about it?
Well, it's pretty new also for our center, and it's most of the time it's temporary because the main problem is with the skin that is with a graft versus so is really battered, so you can't put any plasters on it. So the experience we have that it is for a short period of time, like say one bridle for 3 months, and then you can go back to the normal fixation again.
Okay, so maybe you, if you don't have the details at hand to share on the chat, maybe you could forward me the email and the company, because some hospitals across Europe, they might be interested to use it.
I will send it to you.
And then the nasogastric tube, you said that the end tip that comes out in a few points. So it would be interesting to note your company, the company that produced that tube as well.
Okay.
Yeah, I noticed that the pump that you use is different from some of the pumps in say for example in GOSH we have feeding. We use a lot of nasogastric tube feeding, not only in cancer but in bone marrow transplant, in all sorts of treatment. We use them a lot, and the pumps we use are slightly different than yours. Might be good to share for some hospitals who might be exploring promoting nasogastric tube feeding.
Okay. I can do that. It's no problem. Good idea.
Yeah. So are there any more questions? If people want to raise their hands, turn on your camera and have a discussion about team approach to tube feeding. Sometimes it's very hard, isn't it? Because it doesn't succeed. I know of so many cases where it doesn't succeed. And you would need to, people need to then consider other means of feeding. We do use a lot of gastrostomies in GOSH. And obviously there are some patients who we will keep nil by mouth for the main periods during the bone marrow transplant. And we would introduce total parenteral nutrition, TPN, for that brief period when we keep them nil by mouth, the higher risk bone marrow transplant. I don't know if anybody in this chat, in this group here have got such experiences you want to share. Do feel free to on your mic and share. No, I think there are no more further questions. Do you have anything else to add? Renska is there, whether she has anything to add. Is Renska still there? Renska works in Princess Maxima.
Well,
No?
there's one more thing I would like to add, because in September there is a new webinar from the Princess Maxima, and then we will want to share about our experience about the blended diet.
Okay, so the blended diet as in for cancer patients.
Yes.
And is it a new recipe or is it a new way of feeding?
Yeah, it's a quite new way of feeding, and actually blended diet is actually, it's like homemade tube feeding. It's a totally blenderized feed, with only normal nutrition. For example, with like a sandwich or a milk, a chicken, everything gets blenderized and into a very smooth blend, and then it's given by the parents through the tube. And sometimes some parents at the Princess Maxima Center, they use it. Actually, it's something, it's quite new, but some people use it for their child because they think it's tolerated better than the commercial formulas. Yeah, and that's also what we see. But there are some problems because in order to make it, how do you say it, the nutritionally adequate, it might be quite challenging to make it nutritionally adequate. And so, because you for example, you need a lot of milk to make it thin, and then you need to give like large quantities. But it's something new, and we want to tell something about it in the next webinar.
Yeah, and then there will be a parent who is already very experienced with this kind of blended diet, and she will share her tricks and tips with us.
Good. Yeah. So if you put in the webinar, do we have to register for that webinar? It's a free webinar, right, from Princess Maxima?
No, it's with the COP and it's a nutrition nuggets.
Okay, so in SIOP International.
Yeah.
Okay. Good. So if you have no more questions, we will try to wrap up. It's important to give us feedback because this is series of webinar, and we are going to have another webinar on the 15th July. And that's webinar number 4 in this Nutrition Nugget series. But if you could do your survey, your feedback for this session, so we learn from each session. That's the link there. Okay, there's another question coming up while this is being shared. I'll copy this and put it in the chat so that you can either scan the code or click the link for the feedback. So someone from Greece who works in the bone marrow transplant unit, they usually use TPN when it's severe GI, GVH. Yeah, we do that as well. Mariola, we do that in GOSH. We do TPN just for the brief period when there's severe GVHD where you need to rest the gut. Or in some cases, even at the start of the bone marrow transplant, we rest the gut. So yeah, it's the individual practices of the different centers. So this is the link for the survey, and I've copied the link there. You can either scan the QR code or click the link. Okay, so there's the next webinar, which is in the webinar number 4. We will send the registration link soon in your email box, and if you could publicize it. We are inviting the team from Ireland again, who is going to do overnutrition in pediatric malignancies. This is the next webinar on the 15th of July at the same time, 1 to 2 o'clock in the afternoon, Central European time. So thank you very much for your participation. I hope to see your feedback, and I wish you all the best for the rest of the day. Thank you very much, and thank you very much for to the Princess Maxima team.
Yeah.
Nice to hear your presentation.